Hi everyone, I just wanted to go over my case study presentation. My name is Michael Borenstein and I am from the DC campus. So I had the case study of Jessica. I just want to give a little background information on her and the case. Jessica is a 27-year-old female who was referred to counseling by her employer, Architects United, due to repeated attendance and performance issues. She often calls off work or doesn't bother to show up when she does come to work. She is not completing her projects on time. Her co-workers report that she is refusing to work on group projects with them, causing them to take on more of the workload. On her intake form, Jessica checked the box indicating that she gambles, though she did not list how much she spends. She also checked the box indicating that she consumes alcoholic beverages more than 2 times per week. During her initial interview, she discloses that she goes to a local casino 4 or 5 nights a week. She prefers to sit at one of the slot machines or the blackjack tables, as she finds that these are the places that most men hang around. She doesn't usually spend much of her money, no more than $100 a night, she stated. However, she admits that if she wins any money, she will often spend it as well. During these nights at the casino, she will often be given drinks by the casino itself, or she will allow men to buy her drinks. Typically, she has 6 to 9 drinks daily, which has been consistent for the past 5 years. When drinking, she finds that she can be more social with these men, who in turn buy her more drinks and provide her money to gamble with. So that is the case of Jessica. And as a counselor, after seeing Jessica in counseling, she can be diagnosed with the first disorder of alcohol use disorder. So I'm just going to read over the diagnostic criteria listed in the DSM-5. And so diagnostic criteria A problematic pattern of alcohol use leading to clinically significant impairment or distress, as manifested by at least 2 of the following occurring within a 12-month period. So A1, alcohol is often taken in large amounts over a longer period than was intended. There is persistent desire or unsuccessful efforts to cut down or control alcohol use. 3, a great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. A4, craving or a strong desire or urge to use alcohol. A5, recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. A6, continued alcohol use despite having persistent or recurrent social interpersonal problems caused or exacerbated by the effects of alcohol. Sorry for those little rings. A7, important social, occupational, or recreational activities are given up or reduced because of alcohol use. A8, recurrent alcohol use in situations in which it's physically hazardous. A9, alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. A10, tolerance as defined by either a need for markedly increased amounts of alcohol to achieve intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of alcohol. A11, withdrawal is manifested by the following: either the characteristic withdrawal syndrome for alcohol, and then go back to criteria A or B, set for alcohol withdrawal, or alcohol is taken to relieve or avoid withdrawal symptoms. So that is her diagnosis for alcohol use disorder. And then I have a little video right here on the next slide that shows just a little bit about alcohol use disorder. So if you would like to watch the video, you can pause right now the audio and watch the video from the PowerPoint slide. I'm going to move on and read the next diagnosis that the counselor would give Jessica, and that would be gambling disorder after she sought counseling, and the counselor was able to diagnose her with gambling disorder F630. So the diagnostic criteria are as listed. A. Persistent and recurrent problematic gambling behavior leading to clinically significant impairment or distress. It's indicated by the individual exhibiting 4 or more of the following in a 12-month period. A1. Needs to gamble with increasing amounts of money in order to achieve the desired excitement. A2. Is restless or irritable when attempting to cut down or stop gambling. A3. Has repeated unsuccessful efforts to control, cut back, or stop gambling. A4. Is often preoccupied with gambling, such as having persistent thoughts of reliving past gambling experiences, handicapping or planning the next venture, thinking of ways to get money in which to gamble. A5. Often gambles when feeling distressed, such as helpless, guilty, anxious, and or depressed. A6. After losing money gambling, often returns another day to get even, as in she is chasing one's losses. A7. Lies to conceal the extent of involvement with gambling. A8. Has jeopardized or lost significant relationship, job, or educational or career opportunity because of gambling. A9. Relies on others to provide money to relieve desperate financial situations caused by gambling. And B. The gambling behavior is not better explained by a manic episode. So, some assessments that the counselor would apply to Jessica. The first one that I find beneficial would be the SOGS, the South Oaks Gambling Screening. And it was created by Henry Lejour and Sheila Bloom. It was created to screen gambling addiction, and it has 20 questions. So from studying the SOGS, the assessment showed that it is very valid and reliable when comparing gambling treatment sample to a general population. And overall, the SOGS can be used for different cultures, but more studies need to be done in order to find the appropriate score for each culture, as the SOGS was originally created in the US. The only issue that I see with the test for cultures that speak a different language and need the test to be translated. Some words may not be able to translate perfectly into their spoken language, and this can make it trouble for a client when they take the test if they don't understand parts of the test, since this can be a self-assessed test. The next test assessment tool I would give Jessica is the alcohol use inventory. This is 24 scales with 228 questions to measure different features of involvement with the use of alcohol, and it is administered for adolescents 16 years old and up. From research that I found with the alcohol use inventory, the retest had high reliability, as did the internal consistency for the alcohol use inventory. The only thing is that there's a lack of research on how the AUI affects subgroup populations that are at higher risk for alcohol issues. Another issue is that since the test is self-administered, there can be reports of underreporting, because a client can either misunderstand a question or they can provide misleading answers, so they don't want to feel judged or biased against by the counselor. So there are a few concerns when using this with different cultures. Some cultures allow kids to drink at a younger age, so counselors need to be culturally aware of each culture in order to see if drinking is a norm for some of the clients. Also, since the alcohol use inventory is only for people 16 years and up, this would not be a beneficial assessment to use for anyone younger that needs to be tested for alcohol use disorder. The next slide is one of the theoretical approaches that I would be using on Jessica. Cognitive behavioral therapy. It was pioneered by Aaron T. Beck in the 1960s while he was a psychiatrist at the University of Pennsylvania. Cognitive behavioral therapy is usually a short-term therapy, but there's no standard length of treatment. It is best suited for anyone who is willing and wanting to change any behavior, feelings, and or cognitive thoughts. So during the process of counseling, the main goal will be to learn a new behavior. First, the counselor and client will work together to establish what behaviors want to be changed. So in this case, in order for counseling to work, Jessica has to be willing to change, and as you see, she is willing to change since she is still continuing to seek counseling and she doesn't want to lose her job. In Jessica's case, she would want to change her habits of going to the casino multiple times a night and drinking every night. The counselor will have to use talk therapy to explore Jessica's needs, to go to the casino and find out her feelings and beliefs about her actions of going and all the time drinking. Since Jessica likes to be sociable, the counselor will work with her to find different strengths and weaknesses in order to find other healthy habits to keep her sociable, which would be the behavior aspect of this. Since Jessica doesn't want to lose her job, but she also doesn't want to give up her social life. At first, I believe this will be challenging for Jessica, but some things she can do are to join Alcoholics Anonymous and Gamblers Anonymous, where she will meet people similar to her that are going through the same troubles. This would allow her to meet people and still socialize with others with a common ground and issue, but also it will prevent her from unhealthy behavior she wants to change, while she's still getting that social aspect that she needs. Later on, we will discuss different treatment recommendations for Jessica. I just want to go over just a few of my thoughts as of now. The next theoretical approach I would do is rational emotive behavioral therapy. REBT was established by Albert Ellis in 1956. REBT is also a short-term treatment process that goes along with CBT. The goals of REBT are to alter one's basic values and beliefs, to minimize masturbation and perfection, to help people differentiate between things they desire and must, and lastly, to help people see how giving up perfectionism improves their lives. REBT also works on the here and now. So Albert Ellis had this belief that people have irrational thoughts. Some people have a dire need for things, and in Jessica's case, her dire need was to go to the casino, be sociable, drink, and gamble. This theory would work well with CBT because it helps change people's thoughts and beliefs. So I figured combining this with CBT would be the best way to help Jessica get over and help her with alcohol use disorder and gambling disorder. As Jessica's counselor, they would want to educate her on how she can discover her own irrational beliefs of how she thinks she must go to the casino and how she must meet these guys every night. So throughout the process of REBT, the counselor's role is to encourage clients to discover their own irrational beliefs and thoughts, to make connections of how irrational beliefs lead to emotional disturbances, to challenge clients to modify or abandon their irrational beliefs, and to dispute the irrational beliefs and substitute rational beliefs and behaviors. Since this theory works on the present and since Jessica is at risk of losing her job, this theory combined with CBT I feel would be best with working with Jessica. So the benefits of having both of these theoretical approaches is that it is short-term therapy, which means it would be less expensive. There have been many empirical studies that suggest that these approaches are an effective and efficient treatment for many issues and challenges, as well as diagnosis. But as all theoretical approaches, that they all do have some downsides. The downside of these are that since it is short-term, some clients may need longer therapy and deeper exploration of the past, and since these only work on the here and now, the counselor may need to use a different approach for that client. These approaches are also confrontational, and based on some cultures, it can be seen as rude or disrespectful, and that can impact the therapeutic alliance. This is also only good for a limited range of clients, such as one that are intellectual and that are verbal, because this does involve a lot of thinking and speaking back and forth. Some of the ethical considerations that the counselor has to be aware of are that different cultures have different reasoning processes. The counselor must be culturally competent and aware of the cultural norms for each behavioral norm and cognitive thought processes, which is some of the things I've already explained in the past, how each counselor has to be aware of their client's needs and wants and also their culture. The next is the level of care system I picked. The level of care utilization system, also called the locus, measures 6 dimensions: the risk of harm, functional status, medical addictive psychiatric comorbidity, recovery environment, treatment and recovery history, and engagement. And based off your scores off these 6 dimensions, you're placed into either the 6 levels of care, which are recovery, maintenance, and health management, low intensity community based, high intensity community based, medically monitored non-residential, medically monitored residential, and medically managed residential. So the locus is an assessment tool that will be used on Jessica with her problem of alcohol use disorder and gambling disorder. The purpose of this assessment is to evaluate Jessica's level of care needed when receiving services. This is also so the counselor can establish the level of impact of treatment as well. So I'm just going to explain the level of care, each level of care. The recovery, maintenance, and health management level is the least intensive level of care. It is for clients who have complete treatment from a more intensive level of care but still require a little professional help to maintain their recovery status. The client can obtain these services from a clinic or from community-based services. The client on average would see a community support worker 1 to 2 times a month and a mental health specialist twice a month as well. The next level of service is a low-intensity community base. This is an outpatient service for clients who have a disorder that is not significantly disabling them. The client will seek clinical support about once a week with multiple specialists such as community support worker and mental health counselor. The client will be seen in a clinical setting or also community setting depending on the type of treatment being done. This is where the client gets access to services with the support of a clinician. The next level is the high-intensity community-based level, which is for clients who need a more intensive support but are still able to live within the community. The services are either in a clinic or also within the community base. The client will see a clinician several times a week. There will also be several different treatments being used, and it will be easy access for the client to be able to get to the clinical services. The next level is medically monitored non-residential level, which is the most intensive outpatient community-based level for clients who are able to live in a community setting, but only with significant help and intense treatment and case management. The client is able to come to the clinic or be seen in the community. They have a structured treatment setting with the clinical support available most of the day. So starting inpatient programs are at the medically monitored residential level. The client receives services in a residential setting, but no ability to provide secured care. Treatment is provided on site with needs being met for the client as they live on the site. The center will be staffed all times 24/7 and medicine will be monitored with highly structured social, educational, and rehab activities will be met if there is need. Lastly, medically managed residential is the most intensive level of care. It will be provided with the most secure setting and close monitoring, seclusion, and restraint. Mental health nurses and medically services will be available 24/7. Contact with a clinician will be daily and all material needs will be met as a support of daily living. Community-based resources and mental health support will be the essential elements of the provided services. For Jessica's case of gambling addiction and alcohol use, a counselor would recommend her to a high-intense community-based level. This decision was made based on the fact that Jessica is still able to live in the community and has the ability to work, but her diagnoses are preventing her from going to work. Jessica can attend counseling at the clinic and participate in community support meetings. She does not need a more intensive level of care because she is able to live in the community without needing significant help for her daily needs. So after diagnosing Jessica with alcohol use disorder and gambling disorder, the DSM lists several different severity levels that you can associate the client with. So considering the DSM-5 severity scale, Jessica would be applied to the following levels. She would get moderate severity for alcohol use disorder since she meets 5 of the diagnostic criteria. Jessica would get mild severity to gambling disorder as she meets 4 of the diagnostic criteria. So the moderate level of alcohol use disorder was measured by the number of diagnostic criteria that were endorsed, and according to DSM-5, changes in severity are dependent on the frequency and/or dose of alcohol use. So over time, her severity levels can change depending on how much she drinks. Also, specifying Jessica at the mild level of gambling disorder based on the information that she has given us during counseling. As the counseling process continues, the counselor will be able to gather more identifying information, and they can also adjust the severity based on the number of diagnostic criteria that she meets. Next is treatment. The treatment recommendations I came up with come from a person-centered approach. I want the client, as in Jessica, to establish what goals she wants to specifically work on. So her first goal, she stated, she wants to stop drinking completely and learn ways to prevent herself from drinking if she feels like she wants to drink. So within the next 180 days, so this is what the counselor and Jessica came out with together. Within the next 180 days, Jessica will withdraw from alcohol use by 100% and establish a recovery plan. This is going to be measured by self-report and through treatment with the counselor. The first intervention is talk therapy. The counselor will explore with Jessica triggers that cause her alcohol abuse. The counselor will also help Jessica establish a recovery prevention plan. So the treatment plan will consist of the client and counselor working together, like I stated. The goals will be established by which Jessica wants to work on. By using the person-centered approach, Jessica will be the one that leads where her treatment plan will be going. In order for the treatment plan to be successful, the treatment plan has to identify Jessica's problems with approach for solving them, and also it has to be measurable. The next goal, I focused on her gambling use disorder. She stated, I want to stop gambling completely and learn new ways to establish relationships besides with guys at the casino. So within the next 180 days, Jessica will decrease her gambling habits by 100% as measured by self-report. One of the interventions for this would be CBT. The counselor will utilize behavioral and cognitive coping skills to help Jessica abstain from gambling. Jessica will learn new techniques and other ways to establish relationships and learn skills on what to deal when she gets the urges to gamble. A second intervention was to encourage Jessica's self-efficacy for change toward the goal of developing an action plan for terminating gambling behavior. This intervention would serve the purpose of aiding Jessica with committing to an action plan agreed and geared toward the termination of gambling behaviors completely. Now, all these interventions can be interchangeable based on the alcohol use disorder or gambling disorder, and the counselor has to meet Jessica's needs and where she is at the time of the counseling process. So, lastly, counselor and Jessica have to come up with a relapse prevention plan in case Jessica does relapse or is going to feel like she needs to relapse. The synapse model of relapse prevention therapy. So there are 5 goals of this. The first goal is to assess the lifestyle patterns that contribute to relapse by doing a self-assessment of life, addiction, and relapse history. The second goal is to create a list of personalized warning signs that lead the client back to the use to any addiction. The third is to develop warning sign management strategies and coping mechanisms. The fourth goal is to create a recovery plan that will allow the client to identify and manage critical warning signs as they occur. The fifth goal is to create a relapse intervention plan that will give the client instruction to interrupt the addictive behavior should it reoccur. So the synapse model relapse prevention therapy is a Method for preventing clients from returning to alcohol use after initial treatment and for early intervention if she returns to alcohol use. Gorski came up with this model and believes this model would work best because it allows the client to see patterns in their relapse history and begin to recognize the patterns so they can understand the process and be able to work on the prevention. The goal of the counselor is to explain each procedure, assign homework, process results of the homework. This is so that the client can recognize and manage relapse warning signs by gaining insight and creating new behavioral change. So this is also where CBT would be coming in. The CMRPT uses a family treatment component as well. So if Jessica is living with family, a significant other, partner, or anything, the family is also involved with communication and intervention training around the warning signs. Family members will have a behavioral response if an addiction behavior reoccurs. One of the quotes that Gorski stated was that the primary agent of change is the completion of a structured clinical protocol in a process-oriented interaction among the client, the counselor, and members of the therapy groups. So I believe this would work best with Jessica because she has an above average conceptual skills, she has no severe cognitive impairments, and she has no other disorders that interfere with her ability to participate in a cognitive behavioral therapy program. Helping clients identify strategies and coping skills is a significant aspect of the prevention plan. By having Jessica fully engaged in counseling and willing to participate and engage in the relapse prevention plan, then she is finally deciding factor on if the prevention plan will work for her. So that is all I have for my case of Jessica. I thank you guys for taking time and watching this video. If you have any questions, please ask me. Thank you.